Good afternoon, and thanks for joining us. I'd like to begin by acknowledging the traditional custodians of the unceded lands we meet on today. For me, that's the Wurundjeri people of the Kulin Nation. I recognise their continuing connection to land, waters, and culture, and I pay my respects to elders past and present, and extend this to all Aboriginal Torres Strait Islander people here on our webinar. For those of you who don't know me, my name is Belinda Bravo, and I am the General Manager of Policy and Advocacy at the Victorian Healthcare Association. This webinar is brought to you by TriPeaks. TriPeaks is a collaborative initiative between the Centre for Excellence in Child and Family Welfare, the Victorian Alcohol and Drug Association, VAADA, and the Victorian Healthcare Association. So this project aims to expand cross-sector collaboration and promote good governance and integrate practices across these three sectors. We are delighted to be joined by an excellent panel of speakers to talk about the opportunities for community health-led responses to drug and alcohol consumption. And before I throw over to them, I'd like to introduce our speakers. Firstly, I'd like to introduce Nathan Stamm, who is the Executive Program Manager of Medically Supervised Injecting Room and Alcohol and Other Drugs Programs at North Richmond Community Health. He'll talk today about the work of the Medically Supervised Injecting Room to support consumers who inject drugs. I'd also like to welcome Danny Jeffcott from CoHealth. He's the Outreach Cluster Leader, and he'll be talking to us about his early learnings from establishing a health-led response to public intoxication. Also on the line, we've got Dean Membry and Paul McCartney. They're both GPs and addiction specialists from CoHealth. Dean and Paul will discuss the role of community health in strengthening pharmacotherapy offering in Victoria. I've given each of our speakers up to 15 minutes. At the end, we'll have 15 minutes for questions from the audience. If those of you asking a question can introduce yourselves and your organisation, that would be helpful to our panellists. And at this point, I'd like to throw over to Nathan Stamm. Nathan.
Thank you, Belinda. And just so everybody knows, I've been at the Medically Supervised Injecting Room for coming up to 3 years now. I've recently changed roles, so I'm no longer the executive manager there, but I'm happy to talk based on my experience for the last couple of years. I must say from the outset, working with some of the people who access services at the Medically Supervised Injecting Room, as well as some of the drug and alcohol services at North Richmond, has been such a rewarding and also sometimes challenging experience for me personally. The webinar today is about opportunities for community health-led responses, and I think for certainly for the Medically Supervised Injecting Room, one of the things that, if you've never been there or never had an opportunity to have a look around, one of the things that is really apparent is some of the complex needs and some of the vulnerability of some of the people who access services there. I think, in terms of opportunities, one of the reasons that that's important is because from learnings, when you think about some of the core objectives of something like a supervised injecting facility about reducing adverse outcomes for overdose, that is a core part of it. But equally, one of the other parts for us is about that kind of gateway to healthcare services. One of the things that we in particular learned for a lot of the people who access our services, they have complex needs, and often that's a complex health need, but they also have a lot of other social support requirements, or they're in need of some assistance for that. One of the things that, for a lot of the people who access the services, we talk about a third of the people who access services are either experiencing homelessness or at risk of homelessness. So some of that kind of other supports, think about the social determinants of health, some of those other supports, such as providing assistance for things like housing or people living in difficult situations, particularly related to family violence or otherwise, can have a major impact, a beneficial impact in their lives. So for us, one of the kind of learnings, one of the important things to emphasize is about, the key objective is absolutely about, managing overdose and reducing adverse outcomes associated with that. But when we're talking about kind of impacting people's lives and providing services, I think that, you can't underrate the impact of some of that other social support, for lack of a better description. So that's one thing that I would say. for me, one of the other things that is really apparent is for people who access certainly our service, they do have a lot of complex health needs, but also one of the challenges is that a lot of people report to us that they actually struggle to engage with mainstream healthcare services, or they've had not the best experience sometimes engaging with mainstream healthcare services. So for us, some things such as having kind of multidisciplinary teams, both clinical teams and complemented by other harm reduction services and harm reduction workers, and people from very different backgrounds, has been a really important thing for us to effectively be able to meet the needs of some of the people that engage with our service. And particularly establishing a relationship with people over time, where they will then, once they trust us, they will open up and disclose some of the other kind of needs that they might have. And I think for us, where people do have some complex needs, that kind of relationship building and that multidisciplinary approach has been a really important thing for us. The other thing that I guess we learnt was that on both of those factors, one where we have people who have complex needs and who may not engage with mainstream healthcare, or haven't had a great experience necessarily. One of the other things that we learned was that we need to be able to capitalize on when people put their hand up and say, hey, I'd really like some assistance with whatever that is, wherever we can, to try and capitalize on that at the time. We found even during things like COVID, where we would be offering COVID vaccinations to some of the people who access the service, we would have a COVID clinic right next door in the main community health building. And yet we would lose most people in that very short distance between those two things, either for a range of reasons. But I guess the point I'm trying to make is, for us, where we have people who have a range of other needs or supports that they may be looking for, wherever we can, to try and offer those at the time that people are asking for them. And simply, and I don't mean this in a dismissive way, but simply writing a referral to somebody, hey, why don't you go and follow up over there? For a lot of the people who are accessing our service, that wasn't really going to necessarily achieve what it is that we thought it would. So for us, wherever we can, I know there are complexities associated with this, particularly when we're working with other organisations, wherever we can kind of co-locate services and have services that are available at the time that people are looking for them, that's been a really successful thing for us. Where we've successfully, particularly when we're talking about the injecting room, we've successfully had really long-standing relationships and effective relationships with, for instance, St. V's for our point-of-care hepatitis testing and treatment program, Launch Housing to kind of link in with our helping people address their living situation. Fitzroy Legal, again, for some of our people who may have complex relationships with police. Things like that have been really successful. But also the co-location of our primary care and GP services, and even to an extent, some of our kind of immediate care for dental, and of course for pharmacotherapy. But I'm sure Paul will have a bit more to say about that later. But pharmacotherapy in particular is a really important one for us. So I think that, when we talk about what are the opportunities for us, I think that being a community health service located in the area for us is a really important one, because we know that area really well. We're able to establish relationships with other healthcare providers in the area. And that's a really important one for something like a supervised injecting facility, where it is a bigger approach than can be managed by one organisation. Really, I think that's certainly something that's come through in some of the more recent reports and things like that about the supervised injecting facility. And I think for me, it highlights the importance of a community health service, but also for people with acute or complex needs, being able to have really good pathways to a tertiary hospital, but also where for people who are doing better, pathways to other kind of care for for instance, regular GP practices or otherwise, where they may be able to, once we start them on pharmacotherapy, be actually see that those practitioners for their ongoing care. I think that's a really important one as well. Being able to co-locate services is really important, where referrals can be very hit and miss. If I can describe that in a generous way, they can be hit and miss, but where we want to capitalise on people when they put their hand up. And I think for me also the multidisciplinary team has been a really important one for us as well. I'm going to stop, I'm going to say to everybody, Belinda's surprised because I talk more than anyone else probably on the planet, but I'm going to try to kind of stop there and leave some more questions, question time for later on.
Thanks so much for that, Nathan. Appreciate it, and also the exercising the restraint where required. Over to you, Danny. Danny Jeffcott, the cluster lead from CoHealth, to speak to us on his experience around establishing a health-led response to public intoxication. Thanks, Danny.
Thanks, Belinda. And I'm just going to share my screen. So you've got something to look at other than me. And hopefully my presentation makes more sense as you see the slides, and I can speak to them and as I speak to what we've learned from rolling out the public intoxication response services, the general services component of the reforms of public drunkenness reforms. I would also like to, hang on, slide. Changing. Also like to acknowledge the traditional custodians of the land. For me, that's the Wurundjeri people I'm coming to you from today, and pay my respects to their elders, past and present, and extend that to the elders of the lands where you're dialing in from today. The impact of the previous laws on Aboriginal and Torres Strait Islanders is something that is a feature of the response to the way the laws used to impact on some of our most marginalised people more than they did so on others, and we've been very mindful of that in the rollout of our services. So before the 7th of November 2023, there was a law and order response to public drunkenness, over 3 decades, it was a slow but response, but there was mounting evidence. There's a Royal Commission. There was deaths in custody, including Auntie Tanya Day, and it was largely thanks to the work of her family that led to Victoria coming in line with most other Australian states and repealing the public drunkenness laws. Then after the 7th of November, on the slide. Or after. After, we have a health-led response where instead of a police cell, you're offered community care. The health response is a first for Victoria and really a first for Australia as well. We do have sobering services in other Australian states, but the enhanced model that's been rolled out here in Victoria with assertive outreach services really stands Victoria apart from other states in how we've implemented our response post the laws being repealed. We have, as part of the public intoxication response, there are culturally specific services set up around Melbourne and across Victoria. I'm not speaking on behalf or for those services today, but it's important to acknowledge that those services exist. The intake for public intoxication services it's a call to 000. So And then the call will be, if it's appropriate, be diverted from 000 to the Intact Referral and Dispatch Service. That's run by VAADA, Victorian Aboriginal Health Service. And they do an amazing job of screening and supporting calls. And then if it's appropriate for a general service response, then they patch them through to us. The client journey. So we typically start with engagement. It's a consent-based response. We need consent to engage. We need consent to transport. We need consent before someone can stay with us. Yes, an intoxicated person can provide consent, and perhaps that's something some of you might want to discuss a bit later on, but consent is a critical feature of the service. We don't have powers. The only people who come along with us are those that want to, but we also have a duty of care. So if someone is in need of a particular care and we can't provide it, then we would escalate to an ambulance. We provide transport, but most people, probably 80% of the people we make contact with on the streets, don't require coming back to the sobering centre. They had a plan, they have a home or somewhere to get to. It's just something went wrong with that plan. So, you know, we try and help connect them back to family or friends. But for those that don't have that option, we do have a safe place to bring people back to, and that's our sobering centre in Collingwood. The sobering centre is a nurse-led model, and it's a safe place for people to come and sober up. We're staffed 24 hours a day. A typical stay is for 10 to 12 hours. And staff monitor people throughout their stay. So an assessment's done when people first arrive with us. Depending on the risk assessment that's made, someone will be typically checked on every 30 minutes, but if a bit higher risk, then we might decide to check on them every 15 minutes. Our catchment area is the city, the metropolitan Melbourne, anywhere we can get to within 45 minutes of Collingwood. It's a rather arbitrary saying distance when it's based on time, because, you know, during the day, I'll be lucky to get to Richmond on 45 minutes if there's a football match on, but, you know, in the middle of the night, we can probably get to Dandenong in 45 minutes. But typically, we cover all of metropolitan Melbourne. We've got over 70 staff and a multidisciplinary team. I've mentioned it's nurse-led, and we always have a registered nurse on, but we also have harm reduction workers, dispatch workers and security as part of the staff that are on site. And it's a new day, you know. People are cared for by health workers. I think by anybody's measure, including Victoria Police's measure, they're actually pretty happy that that there's a health response now for people who are drunk. It is a much better outcome, and certainly for the people who use our service, it's a much better outcome for them to wake up in a comfortable bed than in a police cell, and there's no penalty, there's no discrimination, they're not kicked out after 4 hours either, and it might just be a conversation that starts to something else. So I'm going to wrap it up there. I've tried very hard to keep to time. Hopefully I've done just that.
Thanks so much, Danny. Really appreciate that. I'm looking forward to getting into a bit more detail with the panel questions coming up. At this point, I'll turn to Paul McCartney from CoHealth, a GP and addiction specialist, to talk about their role in expanding pharmacotherapy options in Victoria. Over to you, Paul.
Thanks, Linda. Let's see if I can get this working.
Looks good to me.
Yep, it's looking okay.
You might want to put it on presenter view so you've got a bit more.
Yeah. Okay. Perfect. Thank you. Thank you for having us, and thank you for attending, everybody. So I'm hoping you noticed the very subtle psychological cues there of people clapping that there's addiction medicine in community health. It's something that hasn't happened really for a long time. So we were quite excited and very happy that CoHealth chose to have us continue to work with them. So just very brief history. A couple of years ago, Dean and myself decided that it would be good, having had reasonable experience in doing addiction medicine as GPs. We thought that completing the addiction medicine training and specialty program would be a useful thing to do. So we were able to do that part-time as a job sharing arrangement with Western Health. So it was a nice collaboration between Western Health and CoHealth to enable us to do our training. We chose to do our training lining it up directly with the advent of a major health emergency, which probably changed things somewhat, but there you go. We got through and finished our training at the end of last year, and this year CoHealth appointed both of us to continue to work as addiction medicine specialists, and one of our colleagues, Philippe and Naren, has also been working with CoHealth at HealthWorks in Footscray. What we realised when we were working in, so this was theoretically talking about pharmacotherapy. Dean's going to talk about that in about 5 minutes. I'm going to talk about another little project that we've been doing in collaboration with Uniting. So what we realised when we were working in hospitals, was that we saw a number of people coming through to get into a detox or withdrawal facilities. Many patients whose primary drug of concern was alcohol, and they were offered basically versions of the same treatment over and over. Versions of counselling, detox, rehab, without often getting access to evidence-based pharmacotherapy options. So we would see people who've been through treatment, up to 14, 15, 16 times the same treatment without ever being offered just the standard sort of medication. What we were also aware of from our general practice experience is that there was a reluctance of doctors to prescribe medication for alcohol, even when an alcohol use disorder was detected in the first place. So this is a significant problem, and it's so significant, in fact, that it's estimated there's about 1 million people in Australia with alcohol use disorder, and less than 3% of those people with alcohol dependence in Australia are being dispensed the first line medications, let alone the other medications that are also available for people in response to alcohol problems. So what we did, I'd like to say we put together a research team and mounted a major project, and consulted with our executive, and our executive got in touch with the executive of Uniting. But what actually happened was that we gave Rose McCrohan a call, who's the nurse practitioner at Curran Place and works for Uniting, and we said, we've got this idea, what do you think? And she linked us up with the appropriate people in the organisation, and we came up with a bit of a plan for us to be able to provide treatment for people who were involved in the community AOD system. So for those of you listening who aren't aware, if you are seeking assistance with any substance use problem in Victoria, the idea is that you would call a referral line, such as Direct Line, and Direct Line would then refer you to the agency that is responsible for doing the intake in the area in which you're living. So in our area, that's the Northwest, and the agency is Uniting, who does that intake work. So the idea being that we would, people who self-referred or were referred by practitioners into Uniting would have their normal assessments done by Uniting, and then be able to be referred to see us for an assessment and management plan, effectively, in relation to their alcohol problem. So it's, and then be able to continue with the normal community AOD process. Part of the plan was that we would send treatment plans back to GPs, even where GPs weren't necessarily involved in the alcohol treatment, but just almost as an educative tool. And that hopefully, and this is still in a proposal that we've submitted with the Northwest Melbourne PHN, we'll be able to provide education sessions to GPs to develop the capacity of and increase the access to treatment for people. So far, this was just at the end of last year. We got in touch with, I think we got in touch with Rose in about October or so, maybe September. In November, we started taking referrals, and we've had 44 referrals to date. So we're aiming to see 3 or 4 people per week. And the outcomes, we're collecting data, using a REDCap database, but reports from the Uniting Intake team have been overwhelmingly positive, and the people reporting back to their intake workers saying that it was a useful experience. Many of the patients described that they had no idea there was medication to help with alcohol. And as I've mentioned before, many of these people are people who've been involved in the system for quite a long time. So this was a bit of a revelation. There might be things that can help. The majority of the patients are commenced on naltrexone, which is a first-line medication, with the initial aim of controlled drinking. So traditionally, naltrexone has been used as part of an abstinence-based program, but we're using it as a mechanism of controlled drinking. And many of the patients that we see are making dramatic changes to their drinking. For example, just yesterday, I had a follow-up with this man, a 43-year-old man living with his partner and 3-year-old son, is currently unemployed, having worked in the wool industry. For the past 5 years, he's been drinking between 10 and 20 standard drinks every day. His goal initially was to go to detox and rehab. That's why he called. But he realized as he was going through that 3 months away from his family would be, difficult for his family and difficult for him to manage. So we started him on naltrexone 3 weeks ago, and I spoke to him yesterday, and he was very excited on the phone. He said he couldn't wait to speak to me. He was absolutely stunned at the impact and can't believe that he's had 4 alcohol-free days without really trying in the last 3 weeks. His alcohol intake is reduced by 3/4, and he's really starting to feel motivated and ready to get back to work. We've seen this kind of response over and over with the patients that we're seeing. So it's very satisfying work as doctors, and it's fantastic to be able to be linked up with an organisation like Uniting, working in a different model, and being able to combine those 2 models together to provide good care for people. So there's a number of benefits of addiction medicine specialists in community health, we think. So substance use problems are classic chronic conditions. They require long-term treatment, and therefore community settings are the most appropriate. The advantage, as Nathan was talking about, is that you can locate the service with other supports that allows for us to be able to work directly with other practitioners. For example, we have an EMDR practitioner in our facility here at Inner Space, being able to work through people so we can help to manage their physiological issues related to alcohol, and they can have their trauma work done here as well. And it allows for the provision of whole person care. So not just the addiction, which is one of the struggles if people are going to addiction clinics and hospitals. But Dean is just going to now have a chat about pharmacotherapy response. And this is a list of other things that we've other projects we've been involved in since having addiction medicine in community health. Thanks, Dan.
Thanks, Paul. So Paul's fairly preemptive round of applause for addiction medicine in the community. Probably like the context of why we think we're best suited here. So when we started the addiction medicine training program, we were told by our boss, you won't find employment in the community. And once you finish, you will have to take a job in a hospital. And we've been pretty firm in our commitment that we're best suited to being in the community. And we think there's a few examples as to demonstrate why that's the case. The first orange box up in that corner speaks to a crisis in opioid replacement therapy. So it's a crisis. It's a multi-layered crisis. It's a crisis upon a crisis. There's sort of this long burning crisis of an inadequate number of people who are prescribing opioid replacement therapy to people in the community. But there was an instance in the last few years where an elderly GP located in the CBD was retiring and had about 250 patients actively on opioid agonist therapy, methadone or buprenorphine. The government saw this as a bit of a crisis and actually put some money up, which was nice. But the money was very much centred at hospitals. So We know that hospitals provide addiction services, but they're fairly poorly attended, and as a number of reports have shown, that it doesn't really meet the need that's going on in the community, and yet that's continues to be the place where funding goes. I think we need to get a little bit more structured in the way we're providing services and get the services where people can access them, and not just keep stumping up new services and then shrugging our shoulders and wondering why people aren't going there. So with these 250 patients, there was money allocated to a number of organisations, the majority of which were hospitals, who received funding to take on these patients and provide care. Of the 250 patients on active treatment, around 100 just went off and found their own GP. So in private general practice or in community health centres around Victoria, they just source their own prescriber without going through PAMS and the channel that had been created for these patients, which left about 150 patients who accessed care through the appropriate channels. And of those 150, over half of them were seen by us at CoHealth at InnerSpace. So we saw about 78, I believe. And some of the hospitals that received fairly significant amounts of money, maybe not by hospital standards, but certainly by community drug and alcohol standards. So some of those services saw as few as 4 or 6 patients, and yet received, we presume, hundreds of thousands of dollars to do that. And so in an industry that really is chronically underfunded and is crying out for greater investment, we saw that as a real waste of money, and that it affirms our view that we think that specialists sitting in the community actually being accessible to patients is really important. The other thing, I've just seen a message, ORT. So ORT is opioid replacement therapy, which is also previously called OST, which is opioid substitution therapy, or OAT, opioid agonist therapy, or MATOD, medication-assisted treatment of opioid dependence. So methadone or buprenorphine. Aside from just offering better access for people to receive treatment, we also think that having good treatment centres in the community is really important for the reason shown on that top right yellow box. We've really been successful in part of our training program back in hospital was identifying junior doctors who were looking at doing general practice and who had some experience in addiction medicine, the hospital, in hospital-based services, and enjoyed it. And so normally there's a bit of a disconnect in the training pathway that they would then have to go off and do the general practice training or basic physician training in the hospitals, spend a few years doing other stuff, and usually forget all about addiction medicine before they would be eligible to come back into the addiction medicine training pathway. And so what Paul and I did was we tried to catch a number of junior doctors and offer to support them through the GP training program. So that included one of their rotations with CoHealth at 75 Brunswick Street in the first year, and then second year for half of the year to spend at InnerSpace doing an extended skills post. So that post was designed to give them experience prescribing opioid treatment and treating alcohol use disorder and other substance use disorders. And we've been quite successful in that. We've caught about 7 or so junior doctors, some of who have already completed their 6 months of extended skills, and others are doing it currently or lined up. And a number of those doctors have already gone back into the hospital, splitting their time now in the same way Paul and I did with our training. So spending half their time in the hospital, half their time in the community getting trained. We think that's really valuable because the training places were all, for addiction medicine, were all very much in the hospital setting. And that was largely unsuccessful in providing a workforce. And we also know that most treatment goes on in the community. And I think if you can treat people in the community, they're much more likely to be retained in community treatment and continue to treat a large number of people and also be involved in training going forward. Paul, I'm not sure if you'd like to speak to any other boxes there.
Just very quickly. So in addition to what Dean mentioned about us seeing 80 patients out of the 150 of Dr. Bauer's patients in the city, we've started another 500 new patients on treatment in the past year, which is a significant portion of the treatment requirement in Victoria. We're looking to develop a response to rural shortage and do some telehealth in Mildura. We're working on developing a addiction-focused health clinic for the homeless in the CBD as well, working with the Salvos there. So there's a lot of things that could be done outside of the rather protective grounds of hospitals if you're working in the community. So we as I say, we've appreciated CoHealth's trust in us to be involved and their support ongoing, and I look forward to some questions.
Thanks so much to Paul and Dean, and to the rest of our panelists for some great presentations and some real thought starters, I think, for us in terms of the current and future directions for the sector in this space. I've got one question to kind of kick us off, but I think feel free for other people to kind of reach into the question and answer function for Zoom, and we'll put your questions to the panelists. I think this one may be for Paul and Dean, and potentially Nathan as well. How do you see the changes to pharmacotherapy prescribing impacting on your work? This question comes from Sheena, who works at a community health service that may not be able to access pharmacotherapy for their clients, as they are not actually a pharmacy at this time.
So presumably that's referring to the changes to pharmacotherapy that they are now it's now a PBS prescription, which we applaud. Actually, those changes, it's made a big difference to our patients who are on methadone and Suboxone, in now paying for people with a healthcare card $7 a month instead of $7 a day for their treatment. So that federal change has been a really significant one. The impact on people is for people who are having the injectable buprenorphine, where, well, we're saying traditionally, but it's really only been available for 4 years. But over those 4 years, that medication's been able to be held within a practice and given directly by a doctor or a nurse practitioner to patients. And now people will have that medication will have to be accessed through a pharmacy. So it does change things. It makes it a little more difficult. We're hopeful that for a number of places that patients will be able to attend a pharmacy really to have their injection once a month. And that will be a compromise solution for people. So it won't be quite as responsive, but the system will still work reasonably well. And as I say, the overall change to the system, I think, is an overall positive.
Might also add, we are advocating for direct supply where possible. So obviously there was a bit of leeway given where we were meant to be going through PBS pharmacies, and then direct supply was continued at the last minute. And I think that goes until the middle of this year. So we're still strongly advocating for ongoing direct supply to organisations that get a lot of people through their doors and can opportunistically start people up on treatment. We know the value of. I'm sure Nathan would be aware of that, of people accessing services such as the as MCER and being able to, in a moment of motivation, start treatment, and we know how good that treatment is. And so if you're in a community health organisation, you have direct supply, that's certainly something that we hope to be supporting going forward.
Yeah, I would agree with that. And I think that for, certainly for a lot of the people that we see, where, the opioid pharmacotherapy clinic set up at the injecting room has been incredibly successful. And part of that is about accessibility, and to be able to provide people who do struggle sometimes to engage with some of our other healthcare providers, and where they have a really good relationship with staff there, to be able to provide things like LAIB on site. And I'm optimistic, maybe like Dean and Paul, that by the time the current leeway, as it gets closer, maybe something will change in the meantime to make it easier, or else it is going to be particularly problematic, and where it may rely on some individual organisations to have a relationship with a pharmacy, or to have something, but that's a very unique response that some organisations will have and others won't. Kind of like Paul, I think the overall change is amazing. That's fantastic. But for some of the people, and particularly for the people that we see, that also cause that unless something changes, that may cause other issues.
Great, thank you. Our next question is from Scylla. She says, our large regional health service is soon to embark on reviewing how we better integrate AOD support into our area mental health and wellbeing service. What would be 1 or 2 key pieces of advice that you would give us?
I don't know who wants to jump in first. Go for it, Paul.
I was just going to say that I think the main thing that I would be encouraging the service to be adopting is a non-judgmental approach to people who are using substances for any reason, and recognizing that substance use for some people is a choice, and for other people is a means of coping with life, and that the psychological and psychiatric and social support, as Nathan was referring to, for people is so vital for people who are using substances. And the previous situation where AOD services wouldn't see people because they were diagnosed with a mental health condition, and mental health services wouldn't see people because they had substance use, and they were literally left in the middle, was completely well, that was what led to the Royal Commission, of course. So yeah, I think having an attitude of wanting to see people and taking people on and being willing to see them is the most important thing that I would encourage.
I might add that it's often difficult to find a workforce that can provide all of those services at the same time. And so you do tend to get sort of siloing of care by necessity in a sense. It's also really labour intensive to have everyone working together as a team all the time, and you end up really limiting the number of people that you see. But I think there's a really important role for peer support workers and sort of care navigators in journeying alongside the patient as they're accessing those different services. And so having someone who can tie all the services together, even if the services aren't being delivered simultaneously at the same time with the same team, I think can be a really sort of a less labour intensive way of still delivering good outcomes. And I think people with sort of peer support workers and people with lived experience are a really valuable role to play in helping people access care.
I'd only add that pretty similar to what we've said in our presentations, is that you're really looking for the right service at the right place and the right time for the person who needs those services. Recognizing that when some things get short, that people do start to fall through the gaps, and it just the cost down the road is significant. So I highly advocate for a client-centered approach, and not to try to make savings at the cost of what's going to happen down the road.
Yeah, and I think, you know, if I was to add anything, I would say that one of the things that we at the injecting room have been really successful at is through, again, that relationship with people over time, is to be able to identify when people aren't necessarily doing so well, or where some of their behaviour is different to what we would normally expect from them. And often when we probe about that, it is quite often associated with something that's changed in terms of their mental health or their mental health treatment. And so I think being able to knowing the people that use the service, and to be able to kind of identify some of these changes early, makes it much more straightforward, if I can use that description, to intervene earlier to try and address some of those issues. The only other thing I would say is that, you know, some of the most challenging situations that we've had, and to be perfectly honest, where they haven't always gone well, or have been about mostly to do with that kind of co-occurring drug and alcohol issue, and a significant mental health thing that is poorly managed. And if we can avoid getting to that situation, that would be the best.
Thanks. Great comments from the panel. Our next question is from Christopher. It's a bit of a long one. We have a small addiction medicine unit at Dandenong Hospital and Casey, and an AOT clinic in the community at Dandenong. We have big challenges with finding GPs in the community to refer folks back to. They've got an area for pharmacoth network provides some help, and we have some potential funding for an ORT prescribing nurse practitioner, but there is an ORT prescribing desert in the far southeast corridor of Melbourne. Any thoughts from the panel on their experience and what potentially they could do to improve this?
I'll talk again just because that's what I do. Christopher, I've got I don't know if it's good news or bad news, but in a space where I'm working now, the building I'm currently sitting in was previously a needle syringe program more than 20 years ago. And the medical part of InnerSpace was started specifically to respond to the ORT prescribing crisis 20 years ago. So the idea was that the three doctors who were working here, myself, David Jacker and Peter Wright, would see 20 patients each and then be able to move those stabilised patients back into the mythical GP in the community who would continue their care. And we very rapidly each had 40 to 60 patients each and still haven't moved those patients back into the community care. I'm still seeing them. It's been 20 years. So it's not a new problem. And we could have a whole webinar about why, the shortage of pharmacotherapy area, but there's a number of structural reasons for it. It's within the Medicare system, it's not encouraged. I mean, people are perceived as being complex, and some are complex, and sometimes they take a bit longer to be seen. And if you're not somebody who's experienced in dealing with what's perceived as a complicated patient in a practice that's already full in many cases, is not something that doctors look forward to or will go out of their way to do. There's perception that doctors who do this work will be chased after by APRA and that sort of thing for their prescribing. There's a perception that there's stigma. That's a straight up, there's stigma of these folks who are looking for help, that they're going to cause some difficulty in waiting rooms and that sort of thing. And like any group of patients, people who are not having their needs met sometimes cause difficulties. So there's a range of problems. There's been a range of proposals to try and encourage our GP colleagues to get involved, and we've certainly done our share of that encouragement over the years. But it sort of requires a bit of a new way of thinking, I suspect, with some changes to funding. Just for context, in Victoria, the state government has basically privatised or federalised the funding of ORT treatment, whereas some other states don't quite have that model. So there's more of a combined model between Medicare and state funding. So perhaps part of the solution lies with adjusting that.
Thanks, Paul. Any other comments from the panelists? Just to say, Christopher says he's expected that news, but it's good to know that he's not alone. Thanks very much for that feedback.
My comment would be not alone. That's
not alone.
And what Paul said.
And then people in regional and rural areas would echo that even more so. We often see people travelling extraordinary distances to be able to access prescribing GPs. So, but there has been some movement lately, and I really take heart from the rescheduling of pharmacotherapy into the PBS to have it subsidised after decades of charging people an exorbitant amount to access vital healthcare. So if we can slowly dismantle the stigma that's built around people who need ongoing care, then perhaps we can persuade more GPs to come on board. There's probably also an argument for paying them, but
yeah, I agree, Danny. I think it very much is a function of funding. I mean, even with the shortage around Dandenong through those regions, we suspect the state government response is going to be to put money into pharmacotherapy clinics. And those clinics are going to be the ones that are run out of hospitals, not based in the community. Just around GPs, I think we get stuck into GPs a bit, but I think they do quite a lot of the heavy lifting for prescribing pharmacotherapy in the state. Obviously, we'd like more of them, and we'd like that to be almost universal, that it's a skill set that every GP has. But in Victoria, GPs have sort of been the bedrock of treatment of opioid pharmacotherapy. I think the plan, if I just editorialise for a second, I think the plan of getting established GPs and trying to give them more stuff to do probably doesn't work very well. I don't know if you've tried to make an appointment with the GP at the moment, but there's a bit of a shortage and they've got their hands full with lots of other things. So I think our approach to increasing the workforce needs to be looking at doctors in the formative years of their careers and trying to persuade them to come into addiction medicine, because as Paul and I can attest to, it's really rewarding and it's a heap of fun. And our experience has been when you approach junior doctors who have had some experience with addiction medicine, a good chunk of them are pretty willing to consider it for a career. So we'd like to see that some sort of plan formalised around getting access to junior doctors.
And I feel it would be remiss of me not to give a big shout out to our nurse practitioners. We have an amazing clinic at the injecting room, and I think that's a really important part of it. And again, we talk about some of the funding issues and then PBS items, MBS items and things like that. That's also something that's a challenge for our nurse practitioner colleagues as well.
Thanks all. Still waiting for some questions to roll in. There's still time, everyone. But while we wait, I might just pick up on something that occurred to me in Danny's presentation. So Danny, you obviously clearly stepped out that, you know, the sort of outreach service that CoHealth is delivering is based on consent at every point in the pathway. I think you might want to elaborate a little bit more on that, just for some of our participants who might be kind of keen to understand what that looks like.
So consent is well, not just critical. It's something that we need to check in with people along the way. That they're understanding what it is that the service is that they're participating in. But also a cognizant of what that means for them. So that's consent to engage. And that might be as simple as hi, you know, can I offer you a bottle of water? You know, hi, I'm Danny. You look like you're having a tough time. Do you mind if we have a bit of a chat? You know, beginning that engagement before we transport someone anywhere, or, you know, are you okay if we make a phone call for someone? Is there someone that I can call? You know, are you okay with me doing that? Even a person being able to, you know, follow along, demonstrate consent, are all things that we continually check in with. The other thing I'd say that's important to note is that a person can withdraw their consent at any time. So, you know, if they choose to, for whatever reason, to discontinue their engagement, then that's perfectly within their rights, and we would, as soon as it was safe to do so, you know, cease that engagement and allow them to continue on their way. Just the same as an ambulance, you know, you can refuse care, and you know, sometimes it's after the police officers have left. It's actually, you know, I'm good now, thanks very much. I'm on my way. That's when we get back to the centre. There's another assessment done by the nurse at the centre, and it's a bit more comprehensive assessment. And again, we're checking in that the person's okay. And so I understand the complexity. You know, someone's intoxicated, they may have less capacity, perhaps for understanding their situation, but if they've got to the point of intoxication where they're unable to give consent, then they're outside the scope of the service.
Yep.
Belinda, we do have two participants with their hands raised, so they might have a question for you. The first one is Caddy Russell.
Hi, Caddy. Sorry, I didn't see your hand there. Would you like to put the question that you've got to the panel?
Oh, she put it.
You there, Caddy?
Can you hear me?
Yes, I can hear you.
Sorry, the hand was raised by accident.
Oh, okay.
Too late.
That's
You have to
quite
ask
all
the
right.
question now. No, I don't feel like.
Thanks, Caddy. No problem. Who else, Jen, had their hand up?
They also put their hand down, so I think it might have been
That's
two
great.
accidents.
That's good to know. I might just take the chair's prerogative and ask another question, which I think really sort of speaks to all of our panel presentations today. So, I think a sort of consistent theme that runs across all of these presentations and discussions today is this notion that, a lot of the people that community health see are really struggling or have struggled to engage with mainstream services at various points along their client journey. What would the panelists say is the message to the broader health system that they would like them to hear from that? Danny?
It's cheaper and easier. Prevention is worth a pound a cure, so we're better off intervening early than late, and because things only become far more complex when you leave them. The other thing I'd say is that change may happen incrementally, and sometimes it seems almost glacial, the slow rate of change. But when things do change, they change really rapidly. And that's also something that's consistent across our presentations. The injecting room was never going to happen until it did. It took 30 years for public intoxication laws to be repealed, and then bang, we're open in 3 months. Pharmacotherapy, nothing happened really for 30 years, except perhaps the introduction of buprenorphine, and then more recently the injectables, and now finally on the PBS. Maybe something else can happen for Victoria. I still think the Victorian model is actually pretty good when compared to trying to get on a program in other states. So it's all about perspective.
Great points. Thanks, Danny. Paul or Nathan, I can see you've got your mics off.
Yeah, it's a good question, and probably a big one. I think for me there are two things. One would be that where we have some of our people who don't engage well with mainstream healthcare, that when we do see them, to take them seriously and to try and provide whatever services we can at the time, because we may not see them again for some time. And so no matter who you are in the healthcare system, if you come across somebody with issues or complex issues or looking for help, to try and make the most of that. That would be my one. The second one is that you engaging with somebody who hasn't had the best experience as a healthcare professional. If you engage with them in a positive way, that can have a big impact down in the future, where you may not see it at the time necessarily, and they might be a bit prickly or a bit bristly with you potentially. But I guess don't undervalue the impact of having a good experience or creating a good experience for someone.
Great. Thanks, Nathan. Paul, any thoughts from you?
Just very quickly, it's very interesting. In fact, the people I've been seeing for the past 25 years here would be people who traditionally don't sort of fit into with mainstream treatment. But the people we're now seeing through this alcohol program are people who you would normally expect would have good access to mainstream treatment. And what we're seeing in this group of people, and I was seeing in the hospital, is people who we would regard as mainstream not having their healthcare needs met because the people they were seeing were too scared to ask or didn't know what to do. So wouldn't ask about alcohol. So we were seeing young women, women in their 40s coming into the hospital with liver failure as their first presentation in relation to alcohol. It was an absolute disaster, the post-COVID kind of related thing. And it's so I think I don't know that we can do much about all the small general practices, but as community health centres, I would love for community health centres to become places where people would know that they're going to get that appropriate assessment and treatment in relation to things that people are judged for in a lot of other places. So I guess that's a challenge to community health centres to ensure that they provide that angle of treatment for people. miss out on it in other ways.
Excellent. A very hopeful and yet kind of inspiring note to leave our webinar today. I'd like to thank our presenters, Danny, Dean, Paul, and Nathan. And to those of you who've been able to join, and hopefully you've got some inspiration and some reflection and some thoughts for what you might be doing at your own service. So I might close the webinar now. Thanks everyone, and enjoy your afternoon and stay cool. Thank you.